So welcome everybody joining us in our Q&A session today. So we have Professor Jones with us today, a very smart looking Professor Jones with us today. Thank you again for taking the time to join us. We were just having a quick chat there about how this will be the last Facebook Live we'll do with Professor Jones. There's another Facebook Live scheduled next Thursday, but it's Dr. Weltman in Australia, so it's 5 a.m. UK time, if I'm up in time. And that'll be the last one we'll be streaming live on Facebook, and then the first one we'll be doing just here in Click Meeting for the Safe Space. We'll be back again with you, Professor Jones, which will be 2 weeks today. There's information about that on our website, so if anyone's unsure about that or needs some help in terms of joining, please just reach out to us.
And today's quiz is, can anybody recognise what the tie is? Okay, answers in the chat.
Okay. And just before we get started, just remember these Q&As do not take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. And if you need to help with a more detailed issue, please reach out to us on the helpline. Now, I've got 2 asks of you today in terms of trying to create 2 mini videos that I can create. One of them we've actually covered recently, but I would like to just cover it again because we are seeing it coming up. Which is the concerns around OCA and the information that's been out about deaths that have happened and people worried about safety. So I'd like to do a little, maybe a 10-minute slot where I can capture that as a mini video and share if needed. And then also another sort of general one around high cholesterol and statins. But I've got some other questions that have come in too. Do you want to start with the OCA one for us?
Yes. So obeticholic acid has been in trial for 15 years, probably something like that. Time goes by, and it's been approved and has been used pretty much around the world for sort of 8 to 9 years, so depending on the territory where you come from. It's pretty much universally used. I think our centre here has treated about 130 people now with it. So there is a lot of experience using it around the world. Okay. I think it's now up to something like 10,000 patient years. So, 1 patient for 1 year is 1 patient year. So you can get some sense of the experience that comes with it. Okay. Now, everyone who's had OCA has been followed up, so information is collected on everybody. We do it for the UK through UK PBC, and that's part of responsible understanding of drugs. So information is routinely collected to identify patterns, and people will be familiar with the tragedy around thalidomide in the 1960s, and that led to this post-marketing surveillance approach. So you don't just approve a drug and then sell it, you have to see what happens, because the problems with thalidomide were only picked up after it had been licensed. So it's a very established thing around the world. The experience of people who've used OCA around the world, including ourselves, has been very good indeed. We have seen no problems with it at all in any of our patients, and the UK has not seen any problems. Now, the people who have PBC still have PBC. It doesn't cure the disease, and so it's an important condition. That's why you're treating it. And so things will happen to people with PBC who receive a drug, and they'll happen to people with PBC who don't receive a drug. And it's important to realize that, because you're trying to understand, is there any issue with the drug, or is it part of the disease, if you like? So the view, and all hepatologists will tell you, that we spend our life worrying about whether drugs cause injury to the liver, not drugs we use to treat liver disease, but liver in general. There are lots of drugs that can cause problems. An example is flucloxacillin, an antibiotic that many people have had. Millions of prescriptions a year, but it can cause a disease not unlike PBC. Does that mean you shouldn't use flucloxacillin? No, it means you should be aware of it and think about it and do it. So we're all familiar with drugs that cause problems, and we're also familiar with drugs that don't cause problems. And the honest view of the clinicians who use obeticholic acid, certainly in the UK and in Europe, is that this is a drug that doesn't really cause any problems. Now, it does do 2 things, but it doesn't tend to do that for us, because we're careful about what we do. So the 2 things it can do is that can cause itch or make itch worse, usually early within the first 3 months. Okay, So this wasn't expected when we did the trials. I think we described in Newcastle, we had the first person who got the itch. And so we were kind of responsible for that. And it definitely happens. It does not happen in anywhere near, it's a tiny minority of people in practice, but it does happen. What that means in practice is that we would tend to avoid obeticholic acid in people who've got itch, particularly if it's problematic, particularly now that we've got alternative therapies like elafibranor, shortly seladelpar, also bezafibrate. So we would choose which second line therapy to think about based on the amount of itch that people have. And that has basically made the problem go away. I mean, we haven't had problems with anybody getting itch with obeticholic acid for a while. And it's what you've heard me say many times in these sessions. It's good to have choices available. It's good to have lots of drugs so that we can find a drug that is the right one for you. If you've only got one drug, it's more difficult. So itch, it is there. It will be an issue. The vast majority of people with itch with PBC have never taken obeticholic acid. The vast majority of people who take obeticholic acid don't get itch, but you will see more. Okay. Mm-hmm. So that's problem number one. Problem number two is one that was seen very early, indeed, which is in some people with PBC, it made their disease worse. Okay. Now, all the trials show that it makes people's liver disease better in terms of the blood tests and things we follow. But in a small number of people, a tiny number of people, it made their disease worse. Okay. And these were people with pretty advanced cirrhosis. Okay. Now, the problem when you have cirrhosis is that your body has coped with losing a lot of your liver function. And your body does what we call compensate. So you lose up to half of your liver function without it causing you any problems. But you've lost reserve. So you've lost the spare capacity. It's a bit like spending your savings. You've still got enough money in your checking account, but you haven't got any spare. So you lose liver function. And so people are a bit more vulnerable to ups and downs. And if you get to the point where there isn't enough functioning liver, then you'll go into, what we call decompensation. You see the complications. And it is very clear that obeticholic acid can decompensate people with cirrhosis, which is on the edge. Okay. Now, 95% of people who receive OCA do not have cirrhosis. The whole point of OCA is to stop people developing cirrhosis. In fact, we tend not to treat people with cirrhosis because it's not going to really help people. So this is not an issue for the vast majority of people because they don't have cirrhosis. That's the whole point of what people are doing. Now, I do see we have a friend from Michigan, so please excuse me, but I'm going to say a terrible thing, which is this problem exclusively arose in America, okay? And it's because of the way in which drugs are prescribed. So the drugs are prescribable by anybody in America, any doctor, whereas in the UK, we're highly restricted. Only about 30 people in the UK can prescribe obeticholic acid. I can't prescribe it. I have to ask permission of one of my colleagues. Can you imagine what I feel like with that? So we have a very tightly controlled system just to make sure you're not making the wrong decision for people. And we've not seen these problems. In America, where family doctors, office doctors could prescribe it, there were people who were frankly needed transplant, got the drug. And that's where the problem arose. Mm-hmm. Now, that's nothing unique to PBC. It's not unique to obeticholic acid. There are lots of diseases where a drug will push you over the edge. Steroids will do it with autoimmune hepatitis. So it just tells us that we should just avoid developing cirrhosis in the first place. The whole goal of treatment is to stop people developing cirrhosis, because once you've got cirrhosis, it becomes more complicated. And that in a nutshell is everything we're trying to do in PBC at the moment. 10 to 20 years ago, the art of hepatology was to spot the complications of cirrhosis and manage those. We've shunted the whole thing a stage earlier, and it's about preventing cirrhosis. And practice in the UK has been essentially to treat non-cirrhotic people, and we've not seen any of these problems. By the way, I think exactly the same thing will happen with elafibranor and seladelpar. It's nothing to do with obeticholic acid. It is to do with the fact that if you haven't got much liver left, these drugs will behave in an unpredictable way. Now, so on, that was what we knew from a while ago. The prescribing information to stop it being prescribed in cirrhosis was there. It was still being used occasionally in America, and problems are still being seen. But that's an education thing. And then the latest guidance is about concern that it can cause liver injury in people who don't have cirrhosis. Okay. And that's what the concern that was issued before Christmas is about. And I'll be frank, I do not believe it. Okay. And, you know, I am somebody who has the utmost concern for the interests of patients. And more to the point, none of my colleagues who manage PBC patients believe it either. Okay. Now, when you go into the data, it was based on a very, very small number of cases. So we're talking about half a dozen cases worldwide. And when you look at those cases, as I have done, they are people who in fact have got cirrhosis. It just wasn't recognized. And that tells you something. So just because you haven't been told you've got cirrhosis doesn't mean you have it. But this is why we fibroscan people. This is why, if necessary, we do an endoscopy to look for varices. So these were people who actually had cirrhosis. So they shouldn't, at the time they got OCA, got it, but they were labeled as not cirrhotic. So, you know, it isn't what's in the notes, it's what's really happening. And just to tell everybody how absurd this is, one of the people, so much has been made of a poor lady who needed a liver transplant shortly after starting obeticholic acid, who definitely didn't have cirrhosis. Okay. And the regulators are making a big thing about this. This person took obeticholic acid, and within literally a matter of weeks, they needed a liver transplant. I think we would all agree that's terrible. However, the reality is she was on the elective transplant list for itch, okay? And she had her transplant, her organ came up shortly after she went on obeticholic acid. They were entirely unrelated. It was an elective transplant. Her liver function test hadn't changed at all. So that is people adding 2 and 2 together and making about 100. Yes, she was pre-cirrhotic. Yes, she took OCA. And yes, she had a liver transplant, but those were, the OCA was entirely unconnected. And you might want to step back and say, why in God's name did somebody get obeticholic acid in a trial when they were waiting for a liver transplant for itch? You may well ask that. I can't comment on it other than it's bonkers. So that's the problem, is that there's a lot being made of very little here, which has scared people. Mm-hmm. So what would I do? I think and I will add one thing, which is why, you know, why not use one of the other drugs, right? You know, if people are worried about this, no smoke without fire and all that sort of stuff, why not, you know, use one of the other drugs? Okay, well, there are 3 reasons. The first is we don't know how safe the other drugs are. Okay, we didn't know any of these issues at the same point in their development. So just because problems haven't been seen when you've only seen it in practice for a very short period of time does not mean that they won't happen in different forms. So it's a bit of an, you know, simplistic way of looking, say there isn't a problem, and that's because they've not been used in practice. Literally tiny numbers of people. You know, the total number of people who've had elafibranor in the UK is probably the number of people we would start on OCA in a month, right? You know, it's tiny numbers. So just because you don't know there's a problem, you know, doesn't mean there is a problem. So you are swapping something where you know a lot about it for something where you don't know anything about it, on the basis that because you don't know anything about it, there's nothing wrong with it. Well, you know, I don't think you would necessarily think that's very logical in other settings. That's the first. The second is that I think most of us believe that there are essentially 3 levels of effectiveness of treatment in PBC. And this is really important. So the first is URSO, okay, fine for many people. There are many people on this call whom that's fine, right? The second is any of the other drugs added to URSO, and it probably doesn't matter, bezafibrate or obeticholic acid or elafibranor or seladelpar. People will say this is more effective than the other, but there's no evidence. They all work and they all probably roughly the same. So that's your second level. And then the third level, which would be for people who haven't had enough of a response to one of these drugs, is to use a combination. And the only combination we can use is obeticholic acid and bezafibrate. Okay. There are no other combinations that people can use because of the cost of the drugs. Okay, that may change in the future, but right now, if I want to give 3 drugs, it has to be URSO plus bezafibrate plus obeticholic acid. There is also nothing to be gained from adding bezafibrate to elafibranor or bezafibrate to seladelpar because they work in the same way. So the combination of treatment requires different modes of action, and the only way to have an additional mode of action beyond urso and sort of elafibranor seladelpar bezafibrate is obeticholic acid, because it's the only drug in that class. Now, if I was to say about of people who don't respond to urso, probably about 10 to 20% of them, their blood tests will normalize with one other drug, about that sort of level, 10 to 20%. So you definitely see it, but it's not the majority of people. The combination of urso plus OCA plus bezafibrate will give you 70 to 80% normalization. So we're not talking about tiny differences, we're talking about quite big differences. Okay. Now, if you are a 20-year-old with an alkaline phosphatase of 1,000, a family history of PBC, you need really good control. And in that situation, the only thing that will give you really good control is that combination. So if we lose obeticholic acid, we lose the capacity to take this to the next level in those people who need it. And if we don't treat those people, they're the ones who'll need a transplant. So we will have other drugs, but we will lose the capacity to go to the next level, which is very important. And then the final reason why, we still need OCA is that there is no logic in stopping somebody who's been on a drug for 8 years, whose blood tests have normalized and who is tolerating it absolutely fine. There is no logic to swap that person onto an untried treatment for no reason. Okay. So we swap drugs all the time with people, but it's for a reason. It's because they've had a side effect or because it doesn't work. But this is people in offices who don't treat patients issuing diktats to change it. And that's actually wrong, because you lose the potential to control the disease, you potentially gain side effects, all because of very arcane views of, poor clinical practice, I'll be honest. And I think that's what a lot of us object to, is that we're all used to dealing with risk with drugs. We're big boys and girls. We do that all the time. And patients are remarkably sensible about this. And I think we're always lied to side effects. But this is about stopping us doing something that we routinely do, where we see literally no problems with it, but on the basis of evidence that we don't agree with. So in short, to that guidance before Christmas, it's cherry picking cases which tell a story, but that story is not correct, because the story, each of the individual cases is explainable for a different reason. And in the 10,000 patient years of follow-up that the company have taken, we've never seen this. And certainly in the UK, we've never seen this. And so, it's I can't say never happens, but, there are probably 90% of the drugs I use in people with liver disease I've been more concerned about than with OCA. So what would I do if I was a patient now? Okay. So what would I do? So if I was just going on to second line therapy, okay, I think you pays your money and takes your choice. I think there's a good argument for, using one of the other drugs. There's no reason not to. Okay. So you might choose to go down that line. And certainly if you've got itch, there's lots of good reason to use one of the other drugs. Okay. If I had really bad liver blood tests, okay, and urso wasn't touching it, and I and my clinician felt I was likely to need a combination therapy, then I would go on to obeticholic acid and then add in bezafibrate. And in truth, we often start triple therapy. If you've got itch, we would start the bezafibrate first and then add in obeticholic acid, because I wouldn't want to lose the opportunity to have obeticholic acid, with combination therapy. Okay. Mm-hmm. If I was already on obeticholic acid and I'd had a good response to it and I hadn't had any problems with it, I would simply continue with it. Okay. And I absolutely would not. And we are not changing people over. If any patient came to us and said they were worried about it, then we would happily change them to another drug. Of course we would. But nobody has done that in our clinical service. Nobody has done that. And we, at the moment, based on what we know, wouldn't go to change it. So I think there's a lot of protecting of positions. There's a lot of doubling down on all of this. And I think it's unhelpful for patients. And it has the potential to unravel enormous progress. So in short, the answer is move along, nothing much to see here. But we are live to it. Of course we are.
No, thank you. I appreciate that. I know we have talked about it a few times over the last, probably since the turn of the year. We've had a couple of chats about it, but I wanted to make just a little video that we could have on standby for people, because we are still seeing concerns getting raised.
Yes.
Right, so I'll give you our next question, which is around statins, and then if you could do a wee bit for us just around high cholesterol and statins in general. So the question we've got is, I know you've had many statin questions, which we do get quite regular ones, but what I wanted to know was, each time I try a statin, my acid reflux gets so bad. Tried rosuvastatin, pravastatin, and my indigestion is so bad I can't carry on. The cholesterol number is currently 6.6 with LDL 4.7 and HDL 1.2. BP is normal, Curious score is 13, and the patient is 70 years old. And they're just asking for a bit of general advice.
So statins are good drugs. However, they're not perfect drugs. Okay, there isn't a perfect drug, by the way. The more potent drugs are, the more they will also have side effects. I'm gonna have to take my tie off. I know it looks very smart, but it's irritating me now. So nobody's come back and said what it is.
I don't spot it either. What is it?
My OBE tie. It's for an OBE. And I wear it when I'm going to meetings with irritating people who I feel don't really know what they're talking about. And it's to make a very silent point. I've got an OBE and you haven't, so who knows what they're talking about, right? So that's why
you don't need that with us. You don't need that with us.
No, exactly. Right. So statins are very useful drugs. The world is better because we have them than before we had them, but they are not infallible. And like with every drug, there will be winners, but there will also be losers. There are far more winners than there are losers, but there are losers. And of course, what happens in 10,000 people on average is no relevance to you, because what happens to you is what happens to you, right? So that's the background to it. And there is almost nobody, who must take statins, okay? Now, there are 3 reasons why you might take a statin, okay? The first is if you have what's called familial hypercholesterolemia, okay? And there is no doubt, we used to see these families. So these are families where you have a gene that means you make high levels of cholesterol, okay? And I remember when I was a student seeing these families before the advent of these drugs, and they would have cholesterols of 30 and 40, and people would die of heart attacks in their 20s and 30s. It was awful, okay? And statins revolutionized that because it controlled cholesterol levels, literally life-saving. Now, my comment that nobody must take statins, that's the exception. It is literally life-saving for those people. Did you know they used to do biliary drainage to treat it before they had drugs? They bring your bile duct out because, of course, bile acids are made from cholesterol. So they actually used draining the bile to get rid of cholesterol. It was a horrible situation. So in that situation, it's mandatory, right? The second group of people are what are called secondary prevention of heart disease. So heart disease, high cholesterol gets into the wall of the blood vessels. It can then rupture the vessels, causing clots to form, causing a blockage, heart attack, or a stroke, okay? And there is really good trial evidence that if you've had a heart attack or a stroke, that taking statins will reduce the risk of another heart attack, actually irrespective of whether you have a raised cholesterol. So there's more of an effect if you've got raised cholesterol, but even if you haven't got a raised cholesterol, they'll reduce your risk of a heart attack. And that's pretty clear cut, okay? That's pretty clear cut. So if you'd had a heart attack, then taking them on balance is absolutely the right thing to do, okay? There are different forms of them. You get with drugs, you get unique side effects, and then you get what are called class effects. So there are some side effects that are basically a particular drug does it, and there are some side effects that are all drugs in that type do it. Okay, so if you have a penicillin rash, that's down to that particular antibiotic, but getting antibiotic diarrhea is an antibiotic thing, if you know what I mean. So some things are general, some things are specific. So a lot of the side effects, to be honest, are to do with all statins, right? And so muscle pain and things like that, you can try alternatives and see if they're tolerated better, but they're much of a muchness, right? And then the third group of people, and that's usually pretty clear cut. Most people who have a heart attack don't want to have another one. And that's pretty clear cut. And it's the third one that's the problem, because it's much less clear cut. So the third one is what's called primary prevention. So primary prevention is to take somebody who is at risk of a heart attack for whatever reason and to give them this drug to stop them having it. Okay. And you can calculate heart attack risk from whether you smoke, whether you've got high blood pressure, whether you've got diabetes, whether you've got family history. And doctors will put all those numbers into a computer and the computer will give you the answer. But what can happen is that somebody who's entirely well can be told that that they would benefit from statins. The problem is the degree of benefit obviously drops through those three examples. So massive benefit from familial hypercholesterolemia, benefit for secondary prevention, but often tiny benefit for primary prevention. And balancing that against side effects is an issue. Okay. And that's where you have to make an individual decision. Now, so if I got rip-roaring reflux with a statin, okay, then the first question, it's reasonable to try a different one. But for those of you who haven't had reflux, it's a pretty miserable thing if it's bad. Okay, so what's to do? So the first question is, how badly do you want to take a statin based on your cardiac risk? That is absolutely the first question. Because if it's only to reduce a marginal risk based on numbers, if you haven't had heart problems and nobody in the family's had heart problems, it simply, to me, isn't worth it, because you only get one crack at life. Okay, that's a grown-up decision. A doctor will only look at policy, and the policy will be you take it, but it's your life. If you can't sleep at night because you're getting reflux, then marginal advantages in terms of a hypothetical heart attack risk is not good enough for me, right? So I would first of all try a different one. If it's a class effect, I would then ask how badly you would do. This, incidentally, is what we have with urso as well. So how many people are truly intolerant of urso? The answer is not that many. How many people don't take urso because they don't like taking it? It's a larger number of people. But those are people who truthfully don't need urso because their blood tests were fine anyway, or people who we just put straight onto second line therapy. So if you haven't got anything else and you need to take something, you're stuck with what's there. But actually, there are other options. And then the third option is actually a fibrate. So we talked about bezafibrate. Bezafibrate and fenofibrate have been around since the beginning of time, and they are originally cholesterol-lowering drugs. They were in widespread use before statins. They were the statins of the 70s and 80s, and the only reason they're not used for cholesterol control is because people developed statins that are better, and they are better at reducing heart disease, but they are really effective. So statins are better for reducing heart disease risk, but fibrates are still very good cholesterol-lowering drug. They don't have the general heart attack reducing effect. That's the difference. So if you've got highish cholesterol, which you have at 6.7, the LDL is a little bit high. HDL is often elevated in PBC, so it's all a bit of a complex picture. But the net result of all of that is statistically, you would probably benefit from a statin. Whether you as an individual want to do that is a different question. Unless it's secondary prevention after a heart attack, it is one where you need to make a decision. But I, in that situation, would try a fibrate, which in our experience probably causes much less in the way of reflux. So I think, like everything, it's like the old joke, giving up drinking, giving up smoking, giving up fatty food. You don't live longer, it just feels like it. And I think, the rest of your life, with horrible reflux, and the other thing, of course, is with risk. Risk is a funny beast, isn't it? Because people come along and say, I don't want to take this treatment. They come to the clinic and say, I don't want to take this treatment because of the risk. But I point out to them, they took a risk in coming to the clinic this morning because they could have had a car accident. Okay, so they took a risk. So it's paradoxical to take a risk in order to turn down treatment because of the risk. But if they'd stayed at home and sat in a chair, they could have had a pulmonary embolus because they were immobile. So there was a risk coming to the clinic. There was a risk staying at home. Risk is everywhere. It is what's acceptable risk. And that's the point. You can't de-risk everything. So you have to decide what the risks are. And, in this situation, remember that reflux can predispose to cancer in the esophagus. So you might reduce the heart disease risk, but you might introduce another risk. So it's never. So you've got to look at, and this is what's called in medicine is called equipoise, right? So equipoise, we've never talked about that before, but equipoise is where you can make an equal argument pro and against doing something. Okay, so you can, in general, and say antibiotics for bacterial meningitis. It's like that, isn't it? It's so obvious the benefit is there. You don't need to consider it. So this is in one of those. So if it's familial hypercholesterolemia, it's like that. If it's secondary prevention, it's like that. And sometimes it comes down to that. And that's where you good doctors would have a discussion with you where they would lay out both sides of the argument in a neutral way and allow you to make a decision that's right for you. And I do a lot of that in the clinic. We do it around, for instance, transplantation, the timing of transplantation. Here are the pros, here are the cons. Here is what you might think about with one, here is what, but you do it in a neutral way. You're not trying to nudge people in a particular direction because it's equipoise and there is no, what I would do is neither here nor there. Where the further out of equipoise it is, the more you will encourage people not to make daft decisions, and that again, good doctors will help nudge you. Okay, but it is still always your decision, no matter what the doctor says. So try a different statin. Try reflux treatment, of course. Think about why you're taking a statin in terms of your individual risk, and then if you really can't tolerate it and everyone thinks it's a good idea, think about a fibrate.
No, that's great. Thank you for that. We've got a question about asking if all PBC patients have chronic iron deficiency. This patient has chronic iron deficiency and it's having an immense impact on life and work.
Yeah, okay. So iron is something we measure a lot. So as people on this call know, we have a particular interest in symptoms, and a particular interest in symptoms comes down to fatigue and brain fog. We manage itch as well, but a lot of our work is around fatigue. So we always look for the things that might make fatigue worse that are treatable. Okay, so thyroid function or diabetes or whatever, and anemia and iron is one of those things. So we're very familiar with this. Okay, and you see iron levels that are low in PBC patients. Okay, now, is that different to the ordinary population? I don't know, because people of an age of PBC patients get iron deficient. So I don't know if it's more common, but we certainly see it. Now, whether it is caused by the PBC or not is utterly irrelevant, because it's still going to make you tired. Okay, so it doesn't matter why you've got it, you still need to treat it. Okay, now, so what do you do with iron deficiency? So the first thing you need to ask yourself, your doctor will be asking, is there a cause we need to be worried about as to why you're iron deficient? Okay, and what this will do is lead people to look for potential cancers, right? And I'd be straight at it, because chronic blood loss, a little bit of dripping blood into the bowel, is a common cause of iron deficiency. Okay, I have genuinely never investigated iron in a PBC patient and found a cancer, right? But that's what you're supposed to do, and it's obviously the right thing to do, but it's not something we particularly see. We do see anemia related to things that are related to PBC. Okay, so sometimes it's B12 deficiency, pernicious anemia, which is an autoimmune condition. That's not iron deficiency, but you certainly see that in PBC. So B12 injections are very common. But the cause of iron deficiency we see in PBC is celiac disease. So celiac is a sort of allergic reaction to gluten in your diet. It's an autoimmune condition, and about 1 in 20 PBC patients will get it. So when we see somebody with iron deficiency anemia, then we always investigate in a standard way, and they will get their bowel investigated. That's a fact of life, but you don't need to keep doing it. If that's okay, you don't need to keep doing it. And then we would do an antibody test for for celiac disease, and we would look at a few other things, okay? And that's not going to make the iron deficiency better, but it will find if there's a pathological cause for it. And after that, you treat it, okay? And there are 2 treatments for it. I mean, obviously, if you have celiac disease, there's specific treatment. But if you're just treating the iron deficiency, there are 2 ways to treat it. One makes people very happy and one makes people feel very miserable. So the very miserable one is iron tablets, which most people find cause real sickliness, you know, and you're dealing with people who've taken urso already and maybe Questran. So sickliness is kind of par for the course, and iron tablets are horrible to take on top of that. Some people are fine, but a lot of people really struggle. But the nice way is a thing called colloidal iron infusions, which is one of the inventions in medicine in the last X number of years that nobody really thinks about, but has made a big difference. And so basically it's an infusion of iron. We always used to have infusions of iron, but they used to be really horrible for people to get. You get arm pain and feel terrible with them. And this stuff is just, you go to the clinic, sit in a chair for an hour, read a book. It's like getting an infusion of water, and it gives you 3 months of iron, and it's really clever. So we send lots of, we actually have a outpatient facility where we refer people to, they just book in, get it done. And people really like that because it's a very, you know, a very soft way of getting iron back up. And normally where people have got iron deficiency and fatigue, they will, you know, they'll feel a lot better with it. 2 things just to add. The first is, in a lot of people, you never find a reason for it. Presumably, this is just to do with how your body works. I think there are some people who are marginal for the amount of iron they take up. So in some people, you just never find the answer, and that doesn't matter. You don't keep investigating them, you just treat it. So I've got a lady who's been, you know, we've had on colloidal iron infusions for 20 years. And every so often she sees another GP who wants to reinvestigate her bowel and check she hasn't got cancer. But in truth, she's had it for 20 years and she hasn't had cancer for 20 years. So, you know, a bit of common sense with it. The other one, which is really interesting, and I'm not saying this is, I'm not saying that this is something people should go off and do, is that there is a literature on iron supplementation for people with fatigue who aren't iron deficient. And there is evidence that iron improves fatigue in people irrespective of whether they're iron deficient, something to do with the biology of iron, okay? And there was a trial in the BMJ, you know, years ago that shows fatigue benefit. So it's just worth bearing in mind. It is one of the things that sits in the back of our mind. So we would have a very low threshold for treating low iron, actually, because I think there is evidence that it is beneficial, full stop. So we see a lot of it. It never, in our experience, turns out to be anything serious, but that doesn't mean you don't treat it. And I have to say, we pretty much cut straight to colloidal iron these days. The hospital managers don't like it because it's much more expensive. But, you know, go back to what I said before about the statins and reflux. You've got to live a life, you know. And, you know, if you've got things that it is, you know, an hour every 3 months for something which is painless and no discomfort at all, I'm sorry, that's a really good swap to me for quality of life, isn't it?
Absolutely, absolutely. So now I love this next question, but the reason I love this next question is it just shows how informed our patients are. So this question is, if you have been prescribed elafibranor or bezafibrate as a second-line treatment for PBC to help slow disease progression, and you're already currently on cholestyramine for PBC itch, should you continue with the cholestyramine alongside the PPAR agonist, or should you wean yourself off as the PPAR drugs are supposed to help with itch anyway? Or is there not any hard and fast rules?
Yeah, you're right. It's informed questions. So 2 comments on the combination of Questran and elafibranor. So the first is there is no interaction between them, and that is different to obeticholic acid. Okay, so Questran will bind urso and take it out of the body, and it will also bind obeticholic acid and take it out of the body. So if you're taking obeticholic acid and Questran, basically you will lose the benefit of both of them. Okay, now that's not a problem, but you do need to space them apart. So if you're taking urso and cholestyramine, people taking that combination will know that you tend to take the cholestyramine during the day and then take the urso in the evening to space it out. Okay, so the first thing, is there interaction? And the answer is no. Elafibranor is not a bile acid. It does not bind to cholestyramine, so you're fine to take the combination. Okay, that wasn't the question. The question is, do you need to take the combination? And I would do exactly as you suggest. In general, we would try and move away from cholestyramine if we're going to have to need another therapy. So cholestyramine is fine as a treatment, but people sometimes struggle to take it. Add it to the list of things that give you sickliness and all of those things. So you would be optimistic that elafibranor will improve the itch. Okay, so obeticholic acid we've talked about makes itch worse. Seladelpar, elafibranor, and bezafibrate improve itch up to a point. Okay, come back to that. So with a bit of luck, the itch will improve, and you would then be able to drop the cholestyramine. And because cholestyramine is like taking paracetamol for a headache, you take it when you need it, you can control that. So based on your itch, if you've got no itch, then I would start to drop the cholestyramine. I wouldn't stop it suddenly. I would drop a sachet a day, every couple of weeks, and just wean it out, because in general, you're better to be on a single therapy rather than a combination of therapies. Okay, so I think it's very logical. And cholestyramine is what you see is what you get. Treatment, you don't need to continue it. You don't need to take any special precautions when you stop it. I wouldn't jolt the body by suddenly stopping it, but you can wean it out. Okay, the up to a point bit is important, because there's a lot of hype going on at the moment around the new drugs. Okay, and these drugs are good. They offer us something that we don't have at the moment, but they are not miracle drugs. There are no miracle drugs. I mean, what I said before, and they have never been looked at in a clinical trial in terms of their benefit for itch. So no one has done a clinical trial of people with itch to see if these drugs improve their itch, right? Now that might surprise people because of some of the things that are said about them. In fact, what has been shown is that people who are given them in a trial to give better PBC control, who happen to have itch, found that their itch happened to improve to a degree. Okay, but that's not the same as a problem with itch. These were people who didn't have a problem with itch, and their not a problem with itch improved to a certain degree. Now, people with a problem with itch are very different to people who haven't got a problem with itch in terms of the degree of the problem with itch. I mean, so the caveat is these are not the answer to itch. They are a very useful drug for people who need second line therapy who happen to have itch. So I think that's their niche. Whether they are a treatment you should give to somebody who doesn't need second line therapy, but who happens to have itch, rather than something like a rather than a rifampicin, I think it's way too far. That's extrapolating the data. Okay, I don't know at the moment. We treated them using a small number of people for second line therapy, but I don't think bezafibrate is particularly a game changer for itch. I don't think elafibranor is. I don't think seladelpar is. I think they're useful when you're using for another reason as a sympathetic treatment for people with itch. But I think there's a difference between that and using them as a treatment for itch. So the bottom line is that if your itch doesn't get better with those drugs, that doesn't mean it isn't PBC itch or something like that. It indicates that maybe the itch benefit has been a little bit oversold.
Great, thank you. Just before we move on to the next question, I was just going to go back to a comment we've got in the room here, just when we were talking about iron. It's a comment about it being really interesting regarding iron. Can improvements in dietary iron help as well?
Yeah, so I mean, one of the things we've talked about is mea culpa, you need to send me an email, Mo, is that we talked about getting one of my dietetics colleagues to come and join in for one of these meetings. So we'll keep that question back, and we'll do it to all of that. Why iron might help people who aren't iron deficient is a really good question. And as I said, it's likely to be something to do with the biology of iron. Now, the biology of iron in iron supplements is very different to in food. Okay, so it could be that it's something to do with the iron supplements and the chemical status of iron in that situation, or it could be that we've kind of got the amount of iron you need for normal physiology wrong, if you like. So the evidence is of tablets. You can eat a high iron diet and mimic none of those effects. Just by the way, I'm sorry to spoil it, but Guinness is not good for you because it's full of iron. That is, I'm afraid, an urban myth. It's not full of iron, sadly. So the answer is, I suspect it's supplements rather than dietary. It's very unusual to have dietary iron deficiency, and I think you need to, I think you can see it in, people with exclusively plant-based diets. But remember, there's a lot of iron in spinach, all the things your mum tried to make you eat but you didn't want to, like spinach and cabbage and Brussels sprouts. So I think it's around supplements, but it's a really understudied area. And of course, the problem is there's you can get a bit of closed mind thinking about this, that, you don't need iron supplements because you're not anemic. And I think it's a slightly different question. So if somebody's got, can't walk because of, chest pain because they're iron deficient, then it's a case of it's about iron deficiency is the problem. But here we're talking about an association and a treatment for something different. So you've got to be careful. It's one of the things I always say to doctors is make sure you get into the habit of actually answering the question that people ask rather than the question that you think they should be asking. It's the classic one where people go into the clinic and say, I'm really tired. And the doctor says, but your liver function tests are fine, off you go. Answer the question they're actually asking you. So in this situation, the question is, does iron supplementation help fatigue? Not does iron supplementation help iron deficiency? And it's a slightly more nuanced question. So that's a way of me saying I don't know the answer to them.
No, and I will follow up with you actually, because having a dietitian on at the same time would be great as well. So we'll look at doing that.
So she's called Colette. She's working with me. She's doing a PhD. She is a dietitian whose interest is around dietary interventions to improve quality of life. So the reason she works with me is around quality of life, right down our street. And I guarantee you will absolutely love her. She is literally, apart from Mo and myself, the nicest person in the world. And she'll be very scared doing this because it's kind of scary. I'm not scared, but you know what I mean. And so that's why I'll do it with her. But
that would be great.
I think she'll become the official PBC Foundation dietitian.
That's perfect. That's just what we need. I might speak to her to see how her availability is for the patient conference as well. Look out for an email from me about that as well. So that would be amazing. We've got a question here live in the room on Facebook as well. A patient on Urso who has recently started Seladelpar. Should they be taken together or at different times of the day?
I don't think it matters. So Seladelpar, like Urso, like elafibranor, doesn't interact. And so what we tend to suggest is that we tend to suggest people take Urso in the evening. Now, that's partly because once a day treatments are easier than 3 times a day treatments. It's a practical thing, but also to do with how the body enriches bile. So there's a reason to do with bile enrichment. You're likely to get more bang if your side effects with Urso are by how many tablets you take. You're more likely to be able to get away with a lower dose if you take it in one go, because you get more enrichment. Okay, so there are several reasons we tend to suggest taking it all in the evening, but most people do. Seladelpar, most people will take it in the morning, but I don't think that's hard and fast, and I don't think there is any interaction with them at all. I think you do whatever is convenient for you. And to be frank, as somebody who has high blood pressure and forgets his tablets all the time, whatever works as a way of remembering to take it. Now, these drugs do not have an issue with you discontinuing them if you forget a dose. It's not the end of the world. I wouldn't catch up and take an extra dose the next day. I would just go back to the normal dose. But they're not drugs where you get a problem if you discontinue them. Sometimes in life you do. Some hypertensive drugs you get a bounce up. So you've got to be careful. So I'm a rubbish patient is the bottom line. So whatever works for you to help you fit it into your day so you're not ruled by the tablets and allows you to remember whether you've taken it or not.
Yeah, great. So we've got a question: how long after I start fenofibrate therapy can I expect changes in lab results?
So bezafibrate, so you've got fibrates and you've got the PPAR agonists. Just to complicate things, fibrates are PPAR agonists, but for convenience, people talk about fibrates and talk about PPAR agonists. PPAR agonists are elafibranor or seladelpar, and the fibrates, the main one is bezafibrate, but there is a second one called fenofibrate. And in the UK, we have access to both of them. We historically used a lot of fenofibrate. We tend to use more bezafibrate now, but we have a lot of people on both. In different countries in the world, you only have one of them available. So I'm guessing that the person who asked that question is either in America or in Australia, which are the two countries where you only have fenofibrate. We've done some work to look at the effects of, look at the two, they're interchangeable basically, all right? So where people say bezafibrate, fenofibrate is basically the same, okay? So no need to worry about that. We would expect you to see benefit in your blood tests within 3 months, okay? And in truth, probably a little bit before that. So 3 months is going to be a sign of how well this is going to go. It's not the final result, okay? That's really 6 months in most people, but it's going to give you a sense of where this is going. And that's quite important because fenofibrate is probably the least potent of the second line therapies, okay? Now, is that enough? Depends on what your alkaline phosphatase is. If it's 250, it's probably going to be enough, okay? If it's 850, it's probably not going to be enough. Mm-hmm. And so at 3 months, you would continue with it. But if you are, alk phos of 1,000 and at 3 months, it's down to 800, well, it's not going to get in the target range. I mean, because it smooths out after that. So it gives you an idea of where, we call it landing. It gives you an idea of where this is going to land, okay? And if you're not seeing anything by 6 months, you're not going to see anything, okay? Now, it's unusual with these drugs to see no benefit. So we talk about responders and non-responders, but that's a particular defined cutoff, okay? So that's a sort of threshold. And people who, quotes, don't meet that threshold frequently do get some benefit. So it's almost unheard of to get no benefit. The question is, do you get enough benefit? Mm-hmm. And so within 3 months, you should get a clear signal as to where this will land. 6 months is getting close to where it's going to end up at. And then make your decision. And remember, keep emphasizing, we now have options. Availability will change quite rapidly for these things. And it's a case of looking at the options and, versions. Fenofibrate, bezafibrate are absolutely fine for a lot of people, okay? But we're at a stage with all of this where just good enough is not good enough, if you like. We're aspiring to more than that. And so we're aspiring for more than that.
How are you for time? Can I squeeze in another question?
One more question. I have my next meeting has popped up. They don't get my tie either. But one more question then.
Right. I've been told
a lot of these at the moment. So people getting bored of me. They must do.
No. I have been told I have pre-symptomatic PBC, but others have said this isn't a thing and should not be a diagnosis. Is this right?
There isn't. So there isn't such a thing as pre-symptomatic PBC. Okay. So if somebody's got PBC and doesn't have symptoms, they are somebody with PBC who doesn't have symptoms. And actually, statistically, the chances are they won't develop symptoms. So you pretty much with symptoms start out with what you're going to get in one form or another. So if you've had PBC for a year or two and don't get itch, your chances are not going to develop it. I mean, and we don't really understand why some people do and some people don't. But this idea that I'm just waiting for these things to develop is not actually correct. So if you look at the population, for itch, a third of people, have significant itch, a third of people have minor itch, a third of people have no itch, but they're not stages where one goes to the other, goes to the other. It tends to be the way people are. So pre-symptomatic doesn't exist. It implies that it moves into symptomatic, and that's not actually the case. So if you haven't got symptoms of PBC, that's good news. You're actually quite unlikely to develop them, right? There is a thing called pre-PBC, okay, which is where people have the autoantibody the AMA, but their liver biochemistry is normal. Okay, so that's pre-PBC. Most people like that in this day and age probably don't develop PBC. Okay, so most people, their liver blood tests won't become abnormal. We wrote a paper on it a number of years ago, which showed a lot of those people had very mild forms of PBC. I'm not sure that still applies today. We see far more of these people. But if you have got the AMA, but normal liver biochemistry, you don't need any treatment, but you do need somebody just to check your liver blood tests every year. Okay, usually the doctor at home. And then if your alkaline phosphatase goes up, we start you on urso because you then met the criteria for PBC. So pre-PBC is AMA plus, normal biochemistry. There isn't such thing as pre-symptomatic PBC because that implies a linearity which isn't there. Just occasionally we get people with AMA and normal liver function tests who have the symptoms of PBC, and we tend to treat those people because we want to not avoid an opportunity, not to miss an opportunity to improve symptoms. So pre-symptomatic PBC, I think, is an artificial construct.
Thank you. That's us for today. Thank you so much. You can go on to your next meeting now.
Pleasure as always. And I think it's 2 weeks again, isn't it?
2 weeks today, yeah, and that'll be the first one that we will be having here privately in the room in Click Meeting and not streaming on Facebook. Yeah, so good change in terms of a bit more safe space for the questions and answers. Yeah. So thank you again for your time.
Great questions, and I'll see you all in 2 weeks.
Yeah, see you next time. Take care. Bye.